Next speaker this morning is Dr. Arpan Patel from UCLA. Arpan has a unique background in that he has a PhD in public health with a specialty in palliative care, which we really need his guidance on. So he's here to talk about the AASLD palliative care practice guidelines. Arpan.
Thank you for the organizers for having me come here. And it's really a unique privilege to talk about this topic, I think, to such a big audience. And, you know, as Dr. Lumbo was saying, it's really challenging to go through a whole guidance, you know, just in 20 to 25 minutes. So I hope that the pieces that I am able to present to you are salient and able to inform your clinic practice for your patients and their families. So I have no relevant disclosures to report. So in going through the guidance, I think it's going to be important to just take a step back and make sure that we're all on the same page, or refamiliarize you to the concepts behind palliative care, including the definitions and evidence. And then I'll hopefully spend the remaining part of the time to go through the highlights of the guidance and some key recommendations. And in doing so, hope to give you some more elucidation on the specific gaps that we really have for this population, and provide some resources for integrating principles of palliative care. So we had a lot of amazing lectures on how we do need to improve access to liver transplantation when it comes to improving our criteria, to ensuring that patients get access to adopting novel technologies. But I think it's important for us to remind ourselves that the vast majority of patients, unfortunately, won't get access to these curative therapies. This is a study that was done a few years ago showing outcomes of patients with decompensated cirrhosis who have a MELD greater than 15. And you can see over a 3-year period that a vast minority of people will actually receive a liver transplantation. And this rate actually varies depending on which insurance coverage patients have. So Medicare beneficiaries have lower access to transplant, as well as veterans. And this can range from not meeting criteria for transplantation to overt lack of access. And you can see that while 8% of people end up going to liver transplant, the vast majority of individuals will be living with their liver the way it is, and some of them will die. I think it's important in this context to think about and reframe decompensated cirrhosis as a serious illness. And this type of definition actually comes from the palliative care literature, in which we obviously think about patients with serious illness as having a high risk of mortality. But we may not consider is the fact that serious illness also excessively strains caregivers, and it actually negatively impacts quality of life. This is important for 2 reasons. And the first is that it's very clear that our healthcare system is attuned to the fact that we're trying to save patients from dying, but it is not as attuned to the fact of supporting the other 2 aspects of caring for patients with serious illness. So a big aspect of what I'll talk about today is not charging necessarily hepatologists and gastroenterologists with assuming a lot of this care, but building bridges with other services that can help support this care. The same way that we think of integrated models for patients with advanced cancer, when patients have social workers, psychologists, a number of individuals are able to meet these needs. We need to start adopting these models for hepatology. The second aspect of why this is important is because we have to think about the fact that mortality is not all that patients and their families care about when they have a serious illness. They do also care about the burden that they have on caregivers. They do also care about their quality of life. So the way that patients and their families actually balance these 3 issues can be very different and can affect our decision making. So in this context, it's important for us to remind ourselves what palliative care is, just to avoid some misperception. So this is the International Association for Hospice and Palliative Care definition, which is defined as active holistic care for individuals with serious illnesses, especially those near the end of life. The aim of palliative care is to improve the quality of life of patients, their families, and their caregivers. This is not the same thing as hospice. This is not the same thing as end-of-life care, but it's a broader definition that encompasses many aspects of care proximal to that. But it's not surprising that we actually view palliative care as some aspect of the end of life, because the traditional model of palliative care, which started in the 1960s and 70s, was relegated to hospice care. So the traditional model had us doing palliative care at the end of life, but we realized during the 1980s and 90s with the adoption of the palliative care movement that the issues that patients are having at the end of life with poor symptom management, poor caregiver burden, and many other psychosocial issues are happening prior to the end of life. And so the model has now changed, that early integration of principles of palliative care is beneficial and valuable to help support patients with serious illness for the many categories that go beyond just mortality, but also supporting their quality of life and their caregivers' quality of life. So an important aspect of asking ourselves, especially those of us who are not as familiar with palliative care, is what do palliative care teams do? So the first thing is actually to distinguish between what specialty palliative care is versus primary palliative care. So specialty palliative care might be the teams that you are familiar with talking about with hospice and end-of-life care. So they're interdisciplinary teams that consist of not only physicians, but also nurses, social workers, chaplain, pharmacists. They come in many varieties. And the idea is that they can not just be seeing patients in the hospital setting, but they can actually be seeing them in the outpatient setting as well and adopting a continuity model. However, because of shortages in specialty palliative care across the country, which we're trying to fix, a lot of times we have to adopt a primary palliative care model. So this means that aspects of palliative care are done by the clinicians and the primary clinicians treating the patients. And you can argue that many of us as gastroenterologists and hepatologists, if we're providing high quality symptom management and prognostication to patients, are performing aspects of palliative care. So what are the dimensions of palliative care? And this is defined by the National Consensus Project Guidelines for Palliative Care. This includes not just end-of-life care, but high-quality physical symptom management, psychological symptom management, advanced care planning, and addressing social, cultural, spiritual, and existential issues in patients. Much of the evidence that comes from palliative care actually comes from the seminal randomized control trials that was done by Jennifer Temmel in 2010 at Massachusetts General Hospital. So what she did was that she enrolled patients with metastatic non-small cell lung cancer into a randomized trial of 151 patients, in which half of the patients received early specialty palliative care, meaning at the time of diagnosis of non-small cell lung cancer, they had a palliative care team follow them. And they looked at outcomes. Most of these were quality of life outcomes at 12 weeks. What they found was a significant improvement in quality of life scores, which are the ones shown on the left at the end of this trial. What they also looked at were rates of mental health issues. So depression was lower at 12 weeks as well. But most strikingly is that patients who were randomized to early palliative care lived longer than the ones who did not receive palliative care. And they also received lower rates of aggressive end-of-life care. Now, this result should be interpreted with some caution. So what we don't want to say is that all patients who receive palliative care will live longer. But what we should challenge is the hypothesis that many of us have in practice, is that if we refer patients to palliative care early, they're going to die sooner. So I think this was a really important trial that's been replicated several times. That's also been replicated in other serious illness populations. That really shows the value of early palliative care and improving quality of life for patients and their caregivers without limiting life expectancy. So they actually did a secondary analysis, a qualitative analysis of this study, and analyzed, okay, well, so we have this trial where patients were seen by palliative care. What did they actually do during these visits? So they looked at the first, second, third, so on and so forth visits. And what we also found was also counter to what may be intuitive to us. Rather than talking about treatment decisions like DNR or think about scaring patients about end-of-life issues early, those things were actually not talked about that much during the first few visits, but rather there was more of a focus on rapport, symptom management and coping, as well as providing a high degree of support for illness understanding. And it was only towards the last few visits that there ended up becoming more of a transition towards treatment decisions and advanced care planning. I think what this speaks to to is the aspect of when we get these teams involved early, we don't necessarily need to have this conversation be about end-of-life care and distal decision-making. It can really be about exploring patients' quality of life and integrating care in a way that's consistent with their preferences. So in the AASLD guidance, we make a lot of these definitions explicit. So on the left, we have definitions of primary and specialty palliative care, which clinicians can read, whereas all of these aspects of palliative care are driven towards improving quality of life. Primary palliative care is mostly delivered by the primary team or specialists like us, whereas specialty palliative care is delivered by trained clinicians in palliative care. Also on the right are definitions that people may confuse as synonymous to palliative care. So hospice is a medical service provided to patients when they have less than a 6-month prognosis. There are models of care in which patients will have to forego curative therapy. That does not exist in the VA, and California policy has actually recently been passed that curative care can also be provided with hospice care in the past few years. Hospice care can be provided at home or in inpatient settings if patients require continuous care, and they're usually reimbursed through Medicare. Advanced care planning is not exactly the same thing as palliative care, but it's an aspect of palliative care in which we have a longitudinal process of communication with patients that includes understanding their goals, values, and preferences and documenting them in advanced directives, which can then be used towards promoting high-quality decision-making during the patient's medical care and towards the end of life. So the AASLD guidance offers these descriptions to help us as clinicians make sure that when we are using the term palliative care and using these terms, we're being very specific. So I just wanted to make sure that we had that background of what palliative care is and some of those definitions before talking about these key recommendations. And hopefully you'll find the ones that I hit as helpful for your practice. I just wanted to mention that the practice guidelines committee that commissioned us to do these guidelines, I had a recent exchange with Georgiana, who's the chair, and I asked him, like, why did you even come up with this? Like, I mean, it was helpful for me, and I was really proud to be a part of this. But he said the idea was to identify emerging topics in hepatology that our members should need to know about. In hindsight, this was a no-brainer and long overdue. So we were thankful that the Guidelines Committee recognized the importance of at least putting a lot of these principles in a guidance for a large segment of our population that will probably be experiencing some of these issues. I'm fortunate to be joined by a really incredible group of researchers, which include transplant hepatologists, palliative care clinicians, nurses, all of us being researchers and have active practices. So this was really a treat for us to put together over a year's period. It's important for us to know that this is a guidance, not a guideline document. So because while there are significant numbers of randomized control trials that have been done in other serious illness populations outside of decompensated cirrhosis, we don't have any yet that have been completed. We do have a cluster randomized trial featuring 14 centers that is ongoing. That's called the PAL liver trial, which will be complete in the next coming years. But in the absence of that evidence, we had to make a guidance statement. So what we did was we used the National Consensus Project Guidelines for Palliative Care, conducted individual literature reviews of multiple observational studies and non-controlled studies, and we generated a list of really rich amount of data that we used as discussions. And we actually ended up looking at the following domains, which is summarizing the effectiveness of palliative care in cirrhosis in other populations, providing a lot of summary on advanced care planning and high quality communication. A really unique aspect of this guidance particularly is the amount of detail we go into symptom management, which we get, I think I get a lot of questions on in my practice by primary care clinicians when it comes to management of really complex issues. And we also explore psychosocial, spiritual, and cultural aspects of care and end-of-life care. And so this is a long guidance document, 66 statements. And while we're not going to go through all of them right now, I want to offer that this guidance will be a way of communicating between us, our patients, and many of the specialists that see our patients at different aspects of their care, which can include primary care clinicians, palliative care clinicians, and other parts of our teams. So it's important for us to know the gaps in palliative care that we have. And one of them is that patients and caregivers experience significant impairments in quality of life. So this was a study done by Lisi Hansen, who is a researcher at Oregon Health Sciences University, where she took longitudinal cohorts of patients and their caregivers and looked at multiple patient-reported outcomes. The quality of life indices, which is the SF-36, the mean is 50. And you can see that for patients and for caregivers, they have significantly impaired physical and mental quality of life compared to a normal population and even populations with serious illness. The predictors of having a poor physical quality of life end up being hepatic encephalopathy, which is not surprising. Refractory ascites tends to have a significant impact on both the mental quality of life for patients and caregivers, which is also not surprising but important for us to recognize. And relationship quality between the patients and caregivers was protective for improving mental quality of life. So while some of this might seem obvious, I think that what it helps us understand is that there are significant complications of cirrhosis that we have to pay even more attention to, and the relationship between patients and caregivers can actually be a very important avenue. For instance, relieving caregiver burnout can be an important avenue for actually improving the lives of our patients. So just to go through a few of the key statements that in the beginning of the document. So we state that palliative care can be provided to patients with decompensated cirrhosis at any stage of their illness. It could be delivered by members of the care team, which is primary palliative care, or it could be given by patients through a specialty palliative care team. Palliative care does not preclude the delivery of disease-directed care. So when we say we're getting palliative care involved, it doesn't necessarily need to be when the patient's not a transplant candidate or when the patient is in the ICU on tube pressors. It can be much earlier than that. Hospice is different than palliative care because it exclusively focuses on comfort, and which is an appropriate form of treatment with a very poor and a very limited prognosis. And we also state that caring for caregivers is a central component of palliative care and should be provided throughout the trajectory of illness for patients with decompensated cirrhosis. I wanted to move on and talk a little bit about advanced care planning and just in general poor information quality. So this was a systematic review that was in Journal of Hepatology, which reviewed a very high number of studies looking at informational needs in patients with cirrhosis. What we found is not surprising, but probably important to highlight. So patients with cirrhosis and their caregivers have an extremely limited understanding of what's happening with their illness. They need better information about what liver disease is, what the treatments are. They need more psychological and practical support. There was a recent study that came out in Lancet Gastroenterology and Hepatology that showed that compared to patients with IBD and IBS, patients with cirrhosis had health literacy that was astonishingly bare compared to those illness populations. And I think this could be a reflection of limited health literacy and numeracy in our patients, but it could also be a reflection of the lack of information quality that's available to patients across different health settings and potentially online, where a lot of patients are now consuming a lot of their information about their disease and their illness trajectory. I performed a study that was published in JAMA Internal Medicine last year, where I interviewed patients, caregivers, hepatologists, surgeons, social workers, case managers, and palliative care clinicians about what is happening with regards to advanced care planning and providing information and prognostication to patients when they're close to the end of life. What I found, again, wouldn't shock you, but I think it's important for us to recognize that a limited number of our patients have advanced directives, so 0 to 14%, whereas the national average is about 35% for adults. Patients really wanted to have these discussions, but often didn't have these discussions in outpatient settings, whether that was primary care or their specialist. When it came to seeing their specialist, patients often were redirected from talking about dying because specialists often had a very optimistic attitude about supporting their liver disease and their cirrhosis. Clinicians, instead of engaging with patients about conversation about dying, used it as a threat and which I think we do all the time. We tell patients if they continue to drink or they continue their behavior, they're going to die, but we don't explore what dying means to a patient and actually prepare them for dying, which is probably the problem when it comes to the fact that most of them will die. And then transplant teams and specialists avoided discussions about DNR and about advanced care planning. And what that left was a number of families that were completely and wholly unprepared for decision-making at the end of life. And this reflects in the numbers. So we know that only 30% of patients receive palliative care at the end of life, and only 6% receive hospice. Compare that to patients with advanced cancer, when 50% of patients receive hospice. So our guidance statements on advanced care planning and serious illness conversations. Advanced care planning should ideally start when patients are diagnosed with decompensated cirrhosis, hopefully before hepatic decompensation when they lose decision-making capacity. We argue that, again, this doesn't need to be the hepatologist, but someone who's caring for the patient throughout their trajectory of illness should be capable of having these types of conversations with patients about end-of-life care. What can help with that is structured communication frameworks and communication skills training, and also just basically making sure that you're communicating to patients in a language that is preferred by them and not assuming that they're understanding you if they speak a different language from you. This slide just gives what we did, I think, which was very special in this guidance, is actually give high quality communication frameworks that are present in many palliative care guidances and many communication skills programs. I've taken a number of communication skills program and it has impacted my practice significantly. So I think these are important tools that I use every week in my patients, and I encourage you to look at them and consider your own form of training or people on your team to be trained. Because these programs have actually been shown to improve confidence skills, documentation around advanced care planning, the quality of documentation, and also patient surrogate congruence in decision-making at the end of life. In the last few minutes, I did want to talk about symptom burden, and it's probably no surprise that symptom burden is very high in patients with end-stage liver disease and comparable to other serious illnesses. The degree of depression and anxiety is off the charts compared to other serious illnesses, where 1 in 6 patients with cirrhosis have depression, 1 in 2 have severe anxiety. So a real treat of us going through this guidance was actually making sure that there was specific direction with regards to high quality symptom management. Just the highlights are that we stress non-pharmacological managements, making sure that there's a root cause analysis in terms of what's causing symptoms, and making sure that care wherever possible is interdisciplinary. So I'm not going to go through all the symptoms, but I think that this is a helpful guidance for clinicians if they are managing these symptoms in their practice, or if they have a primary care clinician who has questions about how to manage them, they can direct them towards aspects of this guidance. In pain, we talk about non-pharmacologic approaches, which can include a number of things, including topical injections, and treatments. We also talk about systemic therapies, which tend to be the most preferred when it comes to patients with impaired hepatic metabolism. We also talk about non-pharmacologic and pharmacologic approaches to symptoms that can potentially worsen near the end of life. So dyspnea, or even not at the end of life, so like muscle cramps, pruritus, nausea and vomiting. We give guidance on ways you can just talk to patients about options that are not related to medications, as well as options that are related to medications. And we also give a nice overview on medications that we include in our guidance that you should consider for side effects and cautions. And so I've actually sent this very table to a number of primary care clinicians who've asked me questions about pain management and about medications they're starting. I said, here, this is a group of them that you can talk to them about side effects if I don't have the time to address it in my clinic. And I think these types of tools are effective because they actually are one-stop shop when it comes to making sure that we're kind of dotting our I's and crossing our T's when a patient at the very last second in their visit says, but I'm having this issue. So I think that sort of comprehensive availability is effective and valuable. I'm going to skip this slide. So I think what I want to leave you with is that this area requires obvious more research, which we all know as researchers in this space. Some of the things that are kind of on the pipeline that are important are ensuring that the hepatology workforce is becoming more familiar with primary palliative care. I think it's absolutely essential that the education is bidirectional. I can't tell you how many specialty palliative care clinicians I interface with who are very familiar with advanced cancer, but have no clue on how to, of anything related to decompensated cirrhosis. And we shouldn't think of that as a failure. We should think of that as an opportunity for us to educate these groups of really highly qualified clinicians and teams to support our patients. So I think that this is, again, this is unfortunate, but an opportunity for us. It does require some degree of culture change with regards to understanding that patients and caregivers have their own misperceptions of palliative care. Clinicians that we talk to have misperceptions. I've been fortunate to be part of both palliative care and gastroenterology professional societies where we're trying to help bridge these misperceptions and bridge the gaps. We think that in the future, symptom management assessment, inpatient models and outpatient models are things that we want to study and in very high quality randomized trials, which include triggers for specialty palliative care. And of course, an important part is just making sure that we as clinicians can get paid for the services that are rendered when it comes to palliative care. And so adopting infrastructures for this are valuable and something that we should all advocate for. So in summary, decompensated cirrhosis is a serious illness. We should focus our care not just on improving mortality, but supporting quality of life of patients and caregivers. We have to remember that palliative care is an approach to care for serious illness that prioritizes quality of life, and it should be offered at any stage of their illness. And it can be provided by primary palliative care, which is us, or specialists. We need to recognize and not turn away from the fact that we have significant gaps in many aspects of palliative care, but that cross-education and collaboration between groups and building bridges rather than siloing is going to be the ways that we can support our patients and families in the future. Thank you so much.